everybody. Welcome to the We Fix Pain podcast. I'm here with a special guest, Dr. Steve Capobianco. Man, that is a mouthful, Dr. Steve.
Yeah, well, I'll say that you started off on the right foot by just pronouncing my name correctly, but I think you've been there yourself.
Yes. Actually, my last name is Dr. Pappas, but it is like Papa Ioannou, Scantron boxes, fear my name.
No doubt.
Yeah. So we are here with a special guest for the purpose of going over movement and movement strategies and the Rock Tape system. I've got questions. I know our listeners and viewers have questions, so we brought you on.
Great.
But first, what is your origin story? How did a chiropractor end up with a movement company and movement-based products? How did we get here?
We got here on a long road, I guess. I've told this story multiple times, and I think it's morphed over the 12 years that I've been part of part of this evolution of Rock Tape. But I guess the way that I could start the story would be that, I'm just a DC practicing in NorCal at the time. This was in, 2009, 2010. And an individual showed up at my office. I was using Kinesio tape at that time, which would be the grandfather of the brand.
That started a trend.
That's correct, yeah. Dr. Kenzo Kase really should be given credit for developing this model of taping. And so I was using that. I actually trained under Kenzo, which was, if you've ever met him or heard him speak, he's got a really strong Japanese accent, and it's really challenging to even understand what he's saying. But I got so much great information from him, and I saw such great outcomes that I was the Kinesio tape guy in my area, a small area in NorCal. And this gentleman shows up in my office. He had a roll of tape in his hand that he had created, but he didn't know what to do with it. And his story was that he was a cyclist at the time, a competitive cyclist. He had injured his calf, and he went and saw a PT, and the PT applied Kinesio tape on him. And he had good outcomes, but the tape fell off sooner than he was comfortable with, I guess. And so he was, I guess, an entrepreneur. I call him a serial entrepreneur. He had started and sold multiple companies over the previous 20 years, I guess. And so he was in textiles, and he's decided to go and make a better product, according to him at least. And so he came with this product, and he goes, I don't know what to do with it. You're the taping guy. I want you to try it and let me know what you think. So
your reputation kind of led him to you. Like, you're the taping guy, reputation. He brought it to you?
Yeah, he brought it to me. And so I just consider that a fortunate opportunity. I guess I was the only guy taping in the time, so he just went to the closest one that was to him. But the opportunity presented where I tried it, I liked the product, so I called him back in. And it was really at that transition point in my practice. I was in practice probably 10 years at that time, maybe a little bit, about 10 years. And I was transitioning out of the school of thought of a traditional chiropractor, one that basically just uses their hand. And I started using other tools to be able to complement my care. Soft tissue therapies, instrument assisted therapies, and more. And tape was one of those tools that I was getting some good outcomes with, but I had a different way of applying it compared to what Kenzo would teach with the traditional model. So I called, and I should reference his name. His name is Greg Vandendry, so I give him complete credit for developing such a great product. And I called him back in, and I said, I have this model, a movement-based model of applying tape on the body to help someone move, in a more meaningful way. And he says, well, let's join forces and let's make this thing happen. So that's really the origin story. It may be somewhat off if you had a conversation with Greg, but it's pretty close. So I think that would be the start of this company.
A couple beers, a little whiskey, the story can change.
No doubt.
Yes, it's just like Al Bundy has scored 5 touchdowns, became 7 touchdowns.
Yeah. The fish was a lot bigger than it probably was for another story, but it was just an opportunity that presented. I jumped on the opportunity because I thought it was a great tool at the time to be able to, complement what I do as a chiropractor. And that's really our model. We could talk about in more detail that, I don't feel that any tool should rule you. You should rule the tool, and that's something that we teach within our curriculum.
And that's really why we have you on the podcast, is how do we fit the right treatment, the right service, the right modality to the patient, and understanding application. So that's why you're our featured guest today.
Great.
So a little bit more of the origin story. How did you end up becoming a chiropractor, a sports chiropractor, and a rehab chiropractor? How did that evolution come? Because the perfect storm, right place, right time, got involved with the company. But what led to all that transpiring in the first place?
It's a great question. And the origin of that would be probably a more traditional one, that I was an athlete. I'm born and raised in Canada, so the only sports that we had access to were hockey and lacrosse. So I played those sports from an early age and had injuries throughout. It was a chiropractor that was able to manage my symptoms so I could continue to perform. And it wasn't that the chiropractor's hands alone influenced me. It was at the time I was using the term bedside manner. This was the one and only clinical experience that I had that was more of a therapeutic alliance. That's something that I actually deliver in our education now from what I learned from him, was that he wanted my input into the process, and that changed my view of medicine as a whole, from complementary to orthodox medicine. I wanted to represent more of that philosophy. So I guess I was developing that model as a young athlete, and then I went to an undergrad in Toronto in kinesiology. I wanted to get into movement. That was my passion. So I wanted to help others move more effectively. So I thought a kinesiology degree would help. I completed that, and I was like, I need to know more. And so I got a scholarship at the University of South Florida, which brought me to the U.S. And I did a master's in adapted kinesiology, which was working with individuals with neuromuscular disabilities.
Okay.
And I got the opportunity to start to apply some movement-based care to these individuals, and started to see some good outcomes. But while I was there, and this is the one that really kicked me into chiropractic mode, I met another chiropractor that was, for a lack of a better word, an adjunct investigator in a study that I was part of. And so my job was to have they were children in a warm pool, and I was working with spastic cerebral palsy, and a lot of them had a hemiplegia of some sort. So we get them into a warm environment, and in about 30 minutes they were able to extend, and I was able to get them through meaningful movement again. But there were 3 subjects as part of the study that were being adjusted by this chiropractor. He was basically doing upper cervical adjustments, and these kids would be hemiplegic and spastic, I should say. And within seconds, they would be in the normal tone that allowed me to have an extra half an hour of time.
Instead of flexor and an extensor.
Exactly. So I was, I've had the experience. I've been adjusted most of my life, but I never had that aha. Like, that immediate outcome was profound to me. So I started
in that population too.
Correct.
Wow.
And so I was inquiring, and he says, I think you would be a great candidate just personality wise. And that's something that I truly believe in, is that I think the profession calls us. Even though we might have a story, you're talking about these backstories of how did I end up being a chiropractor? I think chiropractic, and that's without getting too melodramatic, but I think it called me.
Please, no philosophy.
Yeah, it called me into the profession. And I'm not a traditionalist when it comes to chiropractor, the practice of chiropractic. I don't consider myself, a historian, but I mean, I'm 20 years in now, and there was something there that brought me to this profession. And so ultimately I started to look at, I was going the PhD route. I did my undergrad, master's, and I was
in a very specific area, adaptive physiology, adaptive physical education, very specific.
Right. And so I was moving that direction, and that's what was my path, and the path, rerouted in that experience. I started looking at chiropractic colleges. I started seeing that it was in alignment with my philosophy, and I ended up going to Palmer West selfishly, because I was Canadian and there were other Canadians that I had met, and they had a hockey team, and they had a great hockey team that played in a Division II college, league on the West Coast, obviously. And I just had such a great experience at that college. I'm really sad, unfortunately, that it's closing down. But
announced recently, within the past
they just announced about a couple months ago.
Okay.
And it's a sad thing, but it's understandable. NorCal is not an easy place to live due to the cost of living, and so that they just couldn't manage it, unfortunately. But Palmer still exists, and I'm proud to be a Palmer grad, and that was, I guess that's my story.
That's a really interesting origin story. I had a opportunity when I was a kinesiology student, athletic training student at University of Illinois, to work in adaptive physical education. And they had actually at University of Illinois some of the best wheelchair marathoners of all time. And when you watch them compete and you watch them play basketball or wheelchair marathoning, you think to yourself, what do I have to complain about?
That's right.
They're happy, they're functional, and they're living their best life, as the saying goes. And you're having a bad day, and you're like, that guy is in a wheelchair.
Yeah.
So
it changed my perspective as well.
100%.
And so again, our experiences lead to you and I sitting in this room. So,
that's the sum of it, right?
Yeah. And so I'm just really excited about. I'm 20 years in, and I'm still excited about the next 20. And so that's a good sign.
You're passionate. You chose the right profession. All right, so we have a fun segment here. 5 random questions.
Oh boy.
They're just coming to me off the top of my head. There's no plan here whatsoever. All right, so here we go. So if you had to describe your personality by a flavor of ice cream, what would you choose?
Rocky Road.
Why Rocky Road?
It's the complexity of like some crunchiness and some salt with the spongy. I hadn't been asked this question, so this is off the top of my head. The sponginess of the marshmallow and just the combination of flavors is probably what I'm like. I'm not consistent. Is probably the best way to go.
That's a complex answer to a complex piece of ice cream, right? So second question here, your dream vacation, like bucket list, like I got to do this. This is something that you got to accomplish. Where would you go? What would you do?
Well, I just came back from it. So
awesome.
My family is Italian, Capobianco, and so
no, you don't say.
Yeah, well, it's definitely not an Irish name. And so so I just came back from surprising my mom for her 80th. I just turned 50.
Happy birthday to both of you.
Thank you. And so my brother and I went and surprised her, and we got to explore parts of Italy that we really haven't. My brother surprised me with a Ferrari, rented a Ferrari
that's awesome.
for multiple days. Candy apple red Ferrari, let alone. And we took some drives through the Apennine mountain range, which I had not experienced, even though their home is in the valley of that region, and it was epic.
Nice.
So I'm still reeling on that experience. So if I had to go anywhere right now, it would be back to that area.
Back to Italy?
Mm-hmm.
You had like a Ferris Bueller's Day Off, but you didn't crash the
I did.
Ferrari.
I know. We made it out. But here's a quick story on that. The road that we took is an area in the Apennines. We went to this town called Pesca Seroli, beautiful mountaintop town. But the road is a winding road. It was recommended because of the scenery and the complexity of the road, which allowed us to fully experience this Ferrari, which I'd never been in. And so it was a great drive. But then when we returned, we found out that the road's number moniker was 666, and it had the most amount of deaths, and because of how there weren't any railings or barriers that limited you from falling 500 feet. So we found that out afterwards, but the experience, epic.
Yeah. All right, cool. You're an athlete, right?
I would consider myself one, yeah.
Your favorite piece or modality for recovery? You have a tough workout, you just crushed it, you need to recover the next day because you need to get after it again. What's your favorite tool?
Yeah.
Your personal favorite tool?
A combination of hyper and thermal therapies. So I have a sauna and a cold plunge. And so the combination of the two, by far, have been the best that I have. And I have some high-tech stuff that I've used, but hot and cold therapies, for me, the combination of are the best for my body.
Is it because it's in your bloodline being Canadian that you tolerate the cold pretty well?
And the Italian. So I think I like the heat and I like the cold, and the combination kind of speaks to my environment.
Cool. The evolution of the company. Where's this all headed? This is question 4, by the way.
Yeah, great. It's a movement-based company. So I know that the name is kind of pigeonholes us into thinking that we're just a kinesiology tape company or a tape company, of which obviously is our heritage. But the company from the beginning, and that was one of the main stipulations I had with Greg when we initially created this relationship and founded the company, was that I go, there's the philosophy that I've had the privilege in creating is all based around helping people move. And I've said it a couple times already, in a meaningful way. People, maybe you can comment on this, is that I believe that people come to see us not because they're in pain or lacking in mobility or any other diagnosis. They're coming to us because those things are limiting them from experienced life to where they want. So they're coming to us because they can't move in a meaningful way. That might be picking up their kid, working, playing their favorite sport. So the company's heritage is tape, obviously, and that's one tool that we use to help people move in a meaningful way. But then we've expanded over the last 12 years now, using other tools that we can kind of complement what we believe in.
Last major question. So between being a sports chiropractor and being an athlete, your favorite sporting event that you either A, have worked, or B, have been a spectator that you've enjoyed?
Yeah.
Most memorable sports moment?
Easy. The Kona Ironman finish line.
Awesome.
Especially around midnight, when they cut the time off, when you see, Sister Madonna, coming across the line. At the time, this was in the early 2000s, when I first got to experience it. It was actually right after 9/11. And now that I recall, and her coming across that finish line at 11:58, and people there cheering for her as if she won the race, which she did, and I got to catch her, and it's just that was my job at that time, was catching people coming across the finish line, which is really interesting.
I did that at Chicago Marathon.
Oh, you did? It's fascinating, right? Fascinating. They come sprinting across the line, and then they immediately collapse, and so you're there to catch. And so
and walk them too.
Yeah, we walked them to the med tent, and that by far is my best experience.
Yeah, and there was probably a couple Hail Marys that she said, Sister Madonna.
Throughout, no doubt. No doubt.
All right, so let's get into it here. So they're a movement company, predominantly first known as a taping company.
Yeah.
Kinesiology tape, science or science fiction? What does the data say? What does the research say? Because you hear it from the pundits on both sides. A ton of science, or there's no science. Sure. It's placebo. What say you?
Yeah, I love you calling it out, because the answer is it depends. I'm gonna steal from Stu,
yeah,
who uses that.
He should have a T-shirt.
I bet you he does.
We should all have royalties. And
he just lectured at the Fascial Research Congress just this past week, and just closed the event with just the Stu-ness, I call it, that just develops such insight on what we do as movement therapists. But the it depends answer to that question is that the science is readily available, meaning that there's enough. I'll go through the levels of science, from case reports to case series to randomized clinical trials to systematic reviews. Over the last 10 years, what we're finding is, and I understand where those pundits, how those pundits are having the interpretation that tape might not be a viable tool. The reason I believe that is that the researchers prior to the last 5 to 10 years were asking the wrong questions. And we know that when it comes to science, it all is based on what is the hypothesis? What are you trying to answer, right? Right. What's the design is even more important, but you have to have a question that you're looking to answer. And the question they were looking to answer, which was the immediate fault of many of these scientists, where they were asking the question, can a strip of tape on your skin, either the terms that they would use is facilitate or inhibit a muscle? They were muscular based, meaning their philosophy was, let's see if we can influence the muscular system using only one system. And then could this tape, if we taped it in a specific manner, turn on or turn off a specific muscle? And the research coming back was equivocal, meaning that some of them, my gosh, there was some significant change, and others, there weren't any. And then no one, and still to this date, have been able to answer the question, well, is it a placebo effect? Because how do you create a sham with a strip of tape?
It's hard.
It's difficult, right? So the sham concept, that those that are viewing or listening, you have to be able to rule that out. And there really is difficult to be able to demonstrate that a strip of tape is on or not on your body. So that is still a complexity that has not been solved for. So my view on the literature over the last 10 years is that they've changed their the questions that they're asking. Now they're asking, can we influence pain? Can we, and that includes acute and chronic pain. Can we influence your movement, which really resonates with my philosophy, is that can a strip of tape applied in a strategic way in a specific part of the body influence someone's movement mechanics? And can we evaluate that pre and post? So that's really what's happened in the last several years. And now we have some systematic reviews, which some would identify that as being more the higher level or pinnacle of research, that we're getting enough evidence to suggest that tape is effective. I'm speaking of this elastic therapeutic tape, this category, not just rock tape, but there are multiple brands within this category of elastic therapeutic or kinesiology tape. And they're suggesting that, yes, we can influence pain, both acute and chronic. Yes, we can improve movement dynamics, and we can change recovery. So you asked the question earlier, what's my favorite recovery tool? I should say, as a representative as the company, as rock tape is a great tool. I just find that heat and cold work better for me. But there are there is research to indicate that tape applied to the body after activity can speed recovery, decrease DOMS or delayed onset muscle soreness. So that's really my philosophy now, is that, and maybe I can extend on that, is that it does depend, going back to Stu's concept, is like, what are you trying to achieve? And can a strip of tape influence your outcomes, or the outcomes that you're looking to achieve with that patient or client? So it depends is the right answer, but the research is leaning more towards that. If you're asking the right questions, pain, inflammation, movement, recovery, I think it's a tool to consider, at least.
Now, how do you mentioned the other types, you mentioned the elastic tape, the expandable kinesiology tape, and more of the rigid tape, leuco tape. How do we know which tape is right for the right person?
It's how we practice. I hope that we practice more like this, is the test, retest. I, as a general rule, use this philosophy that if you're not screening, you're not assessing, then you're guessing. And so each individual has a temperature, or has a mode of movement that is unique to them. And that's my philosophy when it comes to movement. I don't believe that there's a movement ideal. And that is something we could talk about if you want, because I'm happy to argue the point that I was conditioned to think that everyone should squat in a specific way with your feet turned out at a specific angle. And I don't believe that that's true. I believe that each individual has a goal in mind, a movement goal that is, and they, according to their architecture, their previous history, their experiences, their understanding of movement, they're going to move in a specific way that might be more effective and efficient for them. So I will screen someone according to a specific goal that they might have, a meaningful movement. And then if I can influence their ability, their effectiveness, which is their ability to make the shape, or their efficiency, how fluid they can accomplish the task in an energy conservation way, then I start to figure out what tools can I use outside of my hands that can influence them for a longer period of time. What I found with tape is that since this style of tape can be applied on your body and it stays on for 3 to 5 days, at least that's how we communicate it, it's a tool that extends what I do with my hands.
Treatment window.
I love that term. So the treatment window is extended. I go, this is my hands on your body. It sounds kind of creepy, actually, but this is extending the benefit I provided you with.
I promise you, no lawyers watch this.
That's right.
This is strictly clinical, so no lawyers are watching this. Right. We're good, man.
It just came out wrong. But ultimately, that's how I do it: is screen, rescreen, and evaluate which tool can actually help me get the extension of that benefit over a period of time.
Gotcha. So what is the science and the physiology behind this? Like, there has to be something from a scientific mechanism that's at least plausible for why a piece of tape can change movement, can alter your pain processing or pain suppression mechanisms. What do you think that is?
Yeah, well, there's still some opinion that's based on theory, and some of the theories being substantiated through the science. And the science should be, if we're talking about a therapy like this that's applied to your body, should be revolving around the science of touch. And previous to this, again, the philosophy was using a strip of tape to literally turn on or turn off a muscle just didn't make sense to me personally. And I had difficulty with that philosophy of thought that we can influence a muscle directly by taping it one way. Correct. So I had difficulty with that, but I still saw some outcomes. As I said, even the literature was showing some outcomes were like immediate, some changes, EMG activity of muscle changing, and then others, there was no change whatsoever. So I was like curious about what was happening. And so as you start leaning into the science of touch, it's ultimately the same as when we put our hands on people. We're stimulating receptors in the system that are communicating with the brain. So our philosophy is revolving around this idea that we stimulate certain mechanoreceptors, these keys in the keyboard, if you will, that are talking to different parts of the brain that actually influence how you move. They influence your pain experience. They influence other factors of human movement. So the science is basically when you apply an elastic strip of tape on the skin, and the skin is the organ. Unless
the largest organ in the body, and we forget about it, right?
Let me ask you, do you recall how much time you spent learning about the skin in your formal education?
Not much.
Right? So I had the same, and I spend quite a bit of time now talking about this organ, the largest organ in the body. Now it's being argued that the fascial system, which is the connective tissue just below the skin, might be even larger now that we're learning more about it. But regardless, this outer part of our body is significant. It is the system that we use to navigate the environment around me. When I put my hands on my patients, on the environment, I'm communicating with my brain and theirs via these receptors. And so tape applied to your skin, specifically elastic tape that has the ability to recoil like an elastic band, creates something that we call, and excuse the terminology, but it's the biomechanical lifting effect. It literally just tense or lifts the skin away from the body. That mechanical stimulation stimulates multiple mechanoreceptors. Some of them are touch receptors that are Meissner's, Merkel discs, actiniae.
Oh, you're getting nerdy on me now.
I know, but those are the receptors that speak to a specific part of the brain that kind of tell us where we are in space, right? That's what the term is, exteroception. It's not proprio, which gives us an indication of where our limbs are in movement. Exteroception is basically our body map. Our map looks like this, and it's housed within a certain part of our brain.
Sensory homunculus.
Correct.
Going back to neuroscience days, that's contained in a specific part of our brain.
Right. And so if you're looking at the science of movement and pain, by improving our sense of touch, improving this map, this sensory homunculus, this map of the body, there's evidence to suggest that as we clarify and improve the resolution of this map, our movement improves and our pain decreases. And
that's a win.
Those are two things that we're looking for, right? So
that's a win.
So I'm taking advantage of the touch science, using tape to extend my hands on a specific body part. I'm using tape to be able to continue that conversation with that part of the brain, to clarify the body map, to start to groove new patterns and patterns of movement and patterns of pain behaviors. So,
how do you explain this? We got dorky and nerdy and clinical.
Yeah.
I love it.
Yeah. Basically.
But how would you explain this in a clinical application to a patient that has, well, what are you doing this? Why does it have to say on me 3 days? So let's role play here.
Yeah.
Your doc, I'm patient that has a million questions is Austin, a ton of engineers in Austin.
Yeah.
But we're looking for the average patient that just has questions. How would you explain that?
Yeah, so let's take a shoulder an example. I just recently had a shoulder surgery that I went through the experience as a patient would as well. And so if we're talking about someone with either acute or chronic pain, if you're experiencing pain, the likelihood of you understanding where that joint is in space is probably poor. So what I'm telling them is that when I put my hands on that body part, or when I put any strip of tape on that body part, I'm improving your awareness of where that body part is in space. That's been shown to help decrease pain and improve your confidence in moving that body part. So I basically say that area is smudged, it's lacking in resolution if we're talking about camera resolution, for example. And I want them to understand that the strip of tape is just bringing awareness, bringing attention to that area that's been shown to help manage symptoms and improve movement. So that's basically my spiel, is that, hey, the area is not clear, we're going to make it clearer to you, and we're going to use this to extend that clarity for the next few days.
Yeah, and I'll use the concept of like, hey, listen, any effect that we have from this treatment is short-lived. The two things that keep it going longer is commitment to your home program. But we can use this tape to kind of, have your body extend this treatment window where you feel like, this light application, this light stretch to the tissue 24/7 has very positive effects locally, but on the brain and on the nervous system. So we're using this to basically create that sense of feeling good, that sense of I can move in a better way for like 3, 4, 5 days. That's kind of, is that fair? Is that good?
More than fair, actually. And again, I call it storytelling, right? So your story has a certain flavor focusing on this idea of building your confidence, building, your confidence in that body part that's been lacking in confidence, which leads to increase in threat.
Yeah.
Like when our brain is under threat, when we're under threat, we have certain behaviors to protect ourselves.
Fight or flight.
Fight or flight, right?
Increased muscle tone, increased mental stress. You may even get pupil dilations, right? All of that.
Right. And we know that our patients that are experiencing pain are under threat. The pain is a component of that system. And so if I can do something, if my hands on their body part say, that feels better, I want to use tools like tape for that individual for that purpose, is to extend that benefit, that window that you referred to. I love your story, and I think it's consistent with what we say.
So let's get off the tape. Let's get into the rock tape system. How would you describe the rock tape system to a person that either has no knowledge of the system or very limited knowledge? What is the system?
Yeah.
How would you describe it?
Yeah, the system, so Rock Tape Education, the platform that we created well over 12 years ago, is a system that we called FMT, which stands for, and it stood for different things over the last 12 years, which is good in my opinion that we've evolved our philosophy. It used to be fascial movement taping, FMT. I'm a fascial geek. I like to research about the system just underneath our skin and how it influences pain and movement. So that was my philosophy at the time when I created the education platform, is that we're influencing this fascial system. So it's fascia, it's movement, and then obviously we're putting tape on the body. So it made sense. But over the years, since the movement model has evolved and we know that it's more systems than just one, we changed it to functional movement training, which allowed us to kind of expand our assortment of tools and understanding of human movement. So FMT, functional movement training, is our education platform. We train, we used to do 1,000 courses a year in the US, and COVID has obviously put a dent in that, but we offer live in-person, live webcast, and on-demand curriculum to movement therapists like ourselves, chiropractors, physical therapists, athletic trainers, massage, and others that interact with patients and clients. And the education platform is based around what the middle of that acronym is, movement. What tools can we complement our traditional therapies, our hands-on therapies, to extend that therapeutic window? So we've expanded from kinesiology tape, which is still consistent. We have instrument-assisted tools, the stainless steel tools that you see. There's
Mohawk.
There's multiple brands out there that have them. We have our version that are called blades, and we have education to teach our philosophy of approach when it comes to instrument-assisted therapies. We have myofascial cupping, kind of like a version of Chinese therapeutic cupping, and we have compressional floss bands, which is like what some would identify as voodoo floss, which is a coined term from Kelly Starrett from used to be Mobility Wad. I think it's
changed. It's the
Ready
State.
Ready State. Thank you. So we created our own version of a compressional floss band, and then we have education that spills into movement re-education as well. So under the FMT platform, multiple tools and multiple courses to help movement therapists like us, to be able to kind of complement their care.
All right, so sniper, one shot, one kill, right? We get one shot, one kill. What does that mean? We got one product here, and we're going to go down the list of products. Who is the right candidate for such product? Let's start with who's the right candidate for myofascial cupping or decompression underneath the skin.
Yeah.
Who benefits?
Yeah, I think it's a great question. It's the ones that can't tolerate compression. So when we're talking about a therapy that creates decompression or suction, I find the best candidates are those when I'm using my hands-on therapy, soft tissue therapy, and the areas that I want to interact with, the tolerance of the patient is poor. They can't tolerate it, and I don't want to add pain to help with pain mitigation. So I use something in the opposite direction. So I use decompression using cupping for those types of cases.
And the tool to find it is direct compression of the tissue, not well tolerated. And then, hey, I'm going the opposite.
Opposite, and still manipulating the tissue, the system, but I'm doing it in another way that's more tolerable.
All right, let's go into the instrument-assisted soft tissue mobilization. One shot, one kill. Who's the patient that needs the instrument-assisted variety?
That's such a good question. You know what? My answer to that are the ones that actually, for a lack of a better term, the ones that are, their expectation is, I want to be manipulated. I want
to physically feel something.
I want to physically feel something. It's like, I'll speak for myself. I'm a bigger individual. I used to see the patients that came to me and said, my previous therapist could not get to the tissue. They wanted me to disembowel them with my elbow to release, quote unquote, release the psoas. And so their expectation is something physical. And so usually, to be honest, it's usually those kind of the elite to pro athletes that have been trained to believe that this physical intervention needs to look and feel this way. Instruments typically work for them better, in my opinion.
Okay, let's go to the hands-on. So if you're an ART guy, fascial manipulation guy, one shot, one kill, who's the person on the table that gets the hands-on?
I think it's the ones that, and it's also a great question. I think it's the ones that are in more of the chronic states. And let me just tell you why I believe that to be true. Our hands, the hands-on body approach, when it comes to the receptors that we're stimulating, there's some evidence to suggest that, as I said earlier, tape can stimulate certain receptors, and I threw out the jargon, which, Meissner's and Merkel's and Paxini, all these receptors. But when it comes to hands-on therapy, there's
I'm getting flashbacks.
Yeah,
there's not good.
There's a receptor system and a central nervous system feedback system called interoception. So it's certain receptors that actually have been studied when it comes to mother-child relationships, primates that are grooming each other.
Bonding, the physical
bonding approach, right? So what I find is that by applying hands-on therapy to patients that are in a chronic pain state that have been disconnected from their body and their social environment, we're talking about that psychosocial, effect on chronic pain sufferers, is that they actually respond better when we put our hands, and it's the relationship that we create through that process.
Therapeutic alliance, therapeutic trust.
Correct. So I feel that chronic pain are the ones that I generally lean more towards hands-on therapies.
Okay, vibration therapy.
Oh, it's another good one. Gosh, these are great ones. So vibration is a new thing on our assortment. I didn't really bring that up, but vibration, you can use vibration with multiple tools. Thank you. But
that's pre-show prep work coming in right now.
Right. Vibration, in my opinion, from what the literature is telling us, is that we could take advantage of different frequencies. We are experiencing vibration throughout our lives, and how our nervous system buffers it is really unique. And so now that we're learning more, and I really give credit to companies like the percussion devices that exist, HyperIce, Therabody, and others in this space that have kind of brought it into the consumer world. They kind of brought a tool that was generally only in the clinical world. Now it's brought into the, the end user can actually get benefit from vibration. And so that's kind of sparked some new research, and the research is leaning towards what frequencies have been most effective. Now that we can take advantage of frequencies that we could never replicate with our hand, I can't move my hand fast enough in a certain hertz level, that I can influence different parts of the brain. And that part that I want to introduce to you, or to introduce to the listeners and viewers, is that interoceptive hub. There's a part of the brain called the insula. It's really central, it's really deep, it's more primitive, and it's really involved with sensing what's happening within the body. And vibration at certain frequencies has the ability to actually stimulate that part of the brain in a more effective way. So going back to the answer, I would use vibration on that same category that I just said. Chronic pain sufferers typically have a disconnected, a really poor resolution of this part of their brain. And if we can talk to it, we can start to improve the clarity of that part. And so I combine hands-on therapy with vibration. So the combination of the two have been shown to be most effective.
Same area? Are you working different areas, different parts of the brain?
I'm a fascial geek. So the fascial system is basically the knee bone is connected to the hip bone kind of philosophy, that the system is all connected.
Yeah. Fascial slings,
tonsillars. Now that we're learning that this fascial system is connected from toe to head and vice versa, we actually have some pathways that we're starting to identify that distribute stress, that distributes touch stress, vibration stress,
load force.
Yeah. So I actually take advantage of that. And so I might put my hands on the immediate area that they're experiencing pain, and I use vibration distant along these lines of stress to see if we can influence their mechanics. And I'm seeing some really cool things that I'm excited about. Yeah,
it'd be really cool to see where this all goes. Vibration is not a new concept, but the utilization is, in the application now, the science is catching up to an old concept. It's the same way with when I first started in my master's degree in athletic training, intermittent compression. We had these pneumatic compression devices. It was a big clunky machine, and we're like, it may work post-surgical. And now it's become a recovery tool.
That's right. That's right. So isn't it the same old story that it takes about 10 years of research to actually see it applied in the market? So we're in that range. I think our understanding of vibration frequencies, that low frequency versus high, have different effects on the system. Now that we know that, we can start to figure out how to apply that.
And the hard part is it takes 15 to 20 years for it to actually be taught back in a curriculum.
Yeah, it's even worse,
isn't it? Worse.
You're right.
Right? Like I still have to tell people, hey, we're not isolating your transverse abdominis today. But my personal trainer told me to do this little tuck thing and suck my belly button in. And I was like, full stop.
Stu would come through that door and attack us.
Full stop. Okay, last major product, the floss bands. Right? One shot, one kill. Who benefits from the floss bands?
The floss bands are unique.
We're not talking about the floss dance. No, don't get twisted.
I don't even know what that is, so I'm glad I don't. But
I have a young kid, so.
There you go. The floss bands was taking advantage of an elastic tube. I wish the science of the implement was more substantial, but it's literally an inner tube of a tire cut open, and so now we're taking advantage of rubber that's applied in a circumferential way. So let's say my elbow is a good example, and that's what got me excited about floss therapy, is that chronic tendinopathies, tennis elbow is the kind of the classic diagnosis. I just had poor results with. I'd never had great results. In fact, I think your style of practice had the best outcomes I actually used to refer to. But the number one patient that I would refer compressional floss band would be chronic elbow tendinopathies. And so it's adding compression, it's literally squeezing it like an anaconda, and then you ask the individual to move and I would suggest in a meaningful way. If it's a tennis player, go through that tennis movement while they have the band on. We're talking about 2 minutes of intervention, and the experience for most people is substantial. So if I had one shot, it would be chronic tendinopathies work really well for that type of therapy.
Is it kind of the same concept as counterforce bracing, where you're trying to distribute load and force theoretically away from the epicondyle into other areas where it can buffer the force a little bit?
But it's only short term, Doc. Like I would agree, right? You're talking about like that kind of classic Chopat type of strap.
Yeah. Whether it's patellar or...
and so you're distributing that stress to that new local, right? But this one is more global. So when you wrap someone with a floss band, you're wrapping a region, not focusing attention on that specific musculotendinous junction, and you're asking them to go through a range of motion. And I believe, and this is what we can potentially talk about, by using MSK ultrasound, we're in this kind of age that we can actually collect data, what's happening under the skin in real time. So I've been using MSK ultrasound, which is just basically a wand applied to the body part to be able to look at what's happening underneath. And what we're finding with floss therapy, and obviously we can't put the sound head over top of the floss, it wouldn't emit through, but at pre and post, we're seeing immediate changes on I call it the slide and glide. Your skin should be able to slide adjacent to the underlying connective tissue, which should be able to slide to the muscle or tendon or ligament. And so when the tissues are fixed, I call it the Velcro effect. When they can't slide and glide, that leads to friction and irritation to those nociceptors, those pain receptors. And so what we're seeing with pre and post ultrasound of the floss band, we're seeing significant improvements in slide and glide. So that's where I think the mechanical effects are happening, and then we can kind of layer the sensory effects that we just talked about is talking to the brain.
Gotcha.
Yeah.
So Doc, one of my favorite questions, and maybe you have some input for me on this, this has been debated in the literature, is giving somebody a general movement exercise, general movement strategy versus something specific like neuromuscular control versus a directional preference exercise. There's a big debate. Like, we don't need to give patients specific exercise. We need to load everybody in functional patterns, deadlift, squats, make them more robust, because exercise, the intervention, doesn't matter what exercise you give. Then there's the other school of thought. We need to give specific motor control exercise for specific problems. And then there's the folks that all they do is look for directional preferences and give them exercise. Where do you sit in this conversation?
I'm a generalist. I'm a disciple of Dan John, if you follow Dan John's work. So Dan John talks about the 5 core movements, push, pull, hinge, squat, and carry heavy things. He will say in a different way. SHI blank. That's right. And so Dan John, those that don't know him, is a strength and conditioning coach, very interesting individual, but has been influential. For someone that's been in practice, is such a simplistic way of thinking, is that your body moves in certain ways. We push things, we pull things, we hinge, we squat, and then we carry stuff. Consistently, and I'll speak, anecdotally for my own experience in clinic as well as my training experience, those things typically work. Someone that is recovering from an injury to someone that's looking for sports performance, if we apply those things generally, we typically help someone move in a meaningful way again. So that's my approach.
Yeah, I'm the same thing. Keep it simple. And then the patient, it depends. Stu McGill, I ain't got to pay him royalty.
That's right.
But, why overcomplicate things? Try to make something functional to the patient. And if they have a problem with daily tasks, well, you're squatting, you're hinging, you're pushing, you're pulling, you're carrying things. I do occasionally dabble into looking for a directional preference in an acute pain patient where we can shut off the pain mechanism with one thing. I'm just going to give you one thing over and over and over again. You can do this like 10 to 15 reps every 2 to 3 hours while you're awake. And when you're better, it's the generalist approach. And I typically reserve motor control for there's a specific timing and sequencing thing that needs to be overcome, often in a patient that has very specific movements like a baseball pitcher. If I notice that, they can't rotate through the hip, I may put them in a, DNS, faux DNS position. But it's a specific timing and sequencing problem in a specific part of the motion. But I don't play too much with that with the average population. Because you can overcomplicate things real easy, and it's counterproductive to your outcome.
I agree. I actually appreciate that approach. And if we take a step back and identify the individual that we're talking to, and look at what is aspirational, what's motivational, what's going to change behaviors, because we selectively could say, my gosh, this type of focal, treatment or training recommendation is really indicated. But if it doesn't translate to the individual and they're not going to follow through with it, I call it buy-in. Like if they're not going to buy in, what does it matter what we think? I just need to get them moving in a meaningful way. So quite often, I might be able to accomplish a focal or a local neuromuscular reactivation approach with a meaningful movement like hinging and sitting, doing butt taps on the wall, and teaching someone to do that actually allows them to understand that this is going to help you get back to the activity that you want to do. Then I have buy-in and I have consistency in a specific recommendation. So those are the soft skills that I think you and I have honed over many years
through failure, right?
And continue to learn, right? So I'm learning. Every patient is an experience for me to learn of how to better communicate and connect and create that therapeutic alliance. So when I say generalist, I'm a generalist because it allows me a greater scope to be able to address the needs of the individual I'm working with, not layering what I think is necessary for each and every person. Yeah,
you're not fitting your algorithm onto the patient. You're letting the situation dictate what tool you're going to pull out of that.
Great way to put it.
Kind of like your system. You got cupping, you got flock, all of them. Like that's why we went through it. Have a different application for the right patient. Yeah. Do you have fast and firm entry points and exit points for patients in the rehabilitation game? Like, I think sometimes folks will fall into a trap of prescribing the same exercises. There's like, here's the sheet, do the sheet.
Yeah.
So what's your entry point for exercise prescription? And then when's your exit point? Well, I know the patient's mastered this and I need to switch the training stimulus, or I need to switch the exercise because their goal has changed. What's your entry and exit points?
It's simple. Without plugging, but the FMT movement specialist was my opportunity to start to communicate my philosophy in that exact approach. Is that my entry point is, and I'm going to use the term effective. I want the meaningful movement, whatever movement they're looking to get back to. I want to be able to get their shape, their body shape, to effectively assume that position. So that's my first goal. And so if swelling is limiting someone from extending the elbow, goal number one is to manage the swelling to get them to effectively extend the elbow, right? So if that's the movement that we're looking to return, everything is targeted toward, let's get you the shape that you want to get back to. And that includes getting that shape with less to little to no pain, right? So that's one of the goals. But I'm not talking about efficiency yet. So effectiveness is your ability to assume the shape to address the goal. So that's my first entry, is getting them to effectively assume the shape. As we go down, then we're going to start talking about efficiency. And efficiency is things that you just talked about: motor control, timing and rhythm, energy conservation. Are we doing this movement? Are you doing it in a jerky, energy inefficient way, or are you doing it in a fluid, controlled, confident way? And so it starts with effectiveness, getting them the shape, and then we start applying efficiency tactics, where we start, integrating neuromuscular control tactics like the Big Five, going to Dan John, to improve your ability to actually do that skill. So that's my approach.
And then exit point, off ramp.
Off ramp is ultimately it's a communication. So I don't have, and I generally will still use my brain just faulted there. So the questionnaires, the objective questionnaires that we have, outcome assessments, and then subjective assessments, and then going through your pre and post testing, all of that still holds true. But ultimately, the exit point is the therapeutic relationship that I have with the patient or client, and them identifying that they feel that they have confidence in that movement to move forward. And I've given them the necessary skills to be able to self-manage. That is my exit kind of criteria. If I've been able to give them the skills so that they can self-manage, they have autonomy of their own body, then I know I'm comfortable with them moving on.
Yeah, I think one of the best things you can do with your winding down treatment with your patient is you start to ask them, like, I'm going to test you, and I want you to go through recall to me what your home program is when you're done.
Yeah.
And then I also need to know, fast and firm, do you feel that you've accomplished your goal?
That's great.
you know, and if they can recite their program and go through their program, go through a couple sets and reps or whatever, and yeah, I'm at my goal. I'm very close to my goal. This plan help me broach it. You've done your job.
That's right. And so I think there's lots of, if you didn't meet a specific standard on an outcome, some would say I need to maintain you. But I take the latter where I'm looking at, do they feel that they have control of their own body and they have the tools to be able to manage if and when they start to revert, then I feel most confident that it's time to separate the relationship as it stands and always leave, obviously, an open door when necessary.
Yep. And a resilient, self-reliant patient is also one that's robust, and I call it, for lack of a better term, mental midgets. You don't want to have a bunch of those because they weigh on you as a provider, but also the patient does better when they rely on themselves. Yeah. And the literature is clearly there to support that. You know, like self-reliant, self-resilient patients do better.
That's right.
So a couple of closing thoughts here. If you had to track the evolution of the company, your company, what you've created for the next 5 or 10 years, what direction are you guys headed?
If you're asking me on the direction of what I create the education and I get the opportunity to create the tools that we're creating, I want to start to diverge away from not the reliance, because the tools should always be there for when we need them. And so something that we talked about before we jumped on air is that we have this saying that we have in our education is that don't let the tool rule you. You should rule the tool.
I like that.
And ruling the tool just means that we have tools available to us, including our hands and our minds, to be able to influence someone. But I'm starting to lean more towards the interpersonal skills, the soft skills, the communication skills, the environmental skills of understanding what environment would be most effective to be able to influence someone. So quite often over the last 10 years, I'm hearing a lot about the biopsychosocial approach, applying a biopsychosocial approach. What I found from that philosophy was, we say biopsychosocial, but we're still focusing our attention on the system, on the biological system, the mechanical system. And we say psychosocial because it's a cool buzzword, but no one really understands how to apply it. And so my goal moving into the next phase of this company is to better understand how we take advantage of the psychosocial relationship that happens between a clinician and a patient, to be able to influence the individual's behaviors through communication and relationship building, which isn't the most.
It's not sexy.
It's not
but it's effective.
I think it's so effective, and its sexiness is relative to the viewer. I represent now a company that obviously is in the business of selling products, right? So I believe that the products are necessary, but this new philosophy that I have isn't necessarily leaning on a specific product. It's leaning on how we communicate, eye contact, my body language,
body posture,
the environment that I'm providing, from temperature to sound, all the other sensory stimulus, including cognitive information, psychological connection, addressing the social environment. You know, what are all those factors that are influencing this person on my table that day? I'm most interested in that. And so it might be taking me to another place, but it is something that is calling me. Just like I said earlier, chiropractic called me. Maybe this is the next direction of my calling.
And I think one of the best people to learn from, and I watched her a couple times lectures, Annie O'Connor. Mm-hmm. She does a great job of getting in the patient's head and really understanding the patient and the patient's story, and really kind of iterating. And I like this analogy. You're the pilot of this plane. Mm-hmm. I'm just the co-pilot. You're taking me for the ride and guiding me where you want to go, and I'll help you navigate the direction.
Right.
And when you see her applying those concepts, and she put on a couple videos of her interacting with patients, you're like, crap, I'm doing it wrong.
Well, wrong is relative, but I mean, like, what we're conditioned to believe.
I'm not as good as that.
Yeah, I think the conditioning model is that, at least in our profession, and I want us to expand, and I truly, and I started the company with the the goal to influence our specific profession to begin with. I was probably myopic in thinking that I wanted chiropractic to go to another level, but this extended now to all manual and movement therapists, thankfully. But now I'm kind of stepping back. Chiropractors are known, as a general rule, if you look at satisfaction rates, they're really high. So I'm kind of leveraging what we learned from people like you and others in our profession. What has given you the ability to connect better to your patients compared to a PT or an occupational therapist or an athletic trainer? What is that? And that secret sauce is our ability to connect.
Yeah.
And so I want to leverage this tool of connection to be able to better influence our patients versus them coming in, being a piece of meat on a table, face down, and I'll see you in 20 minutes.
Or you're just in a corner doing exercises for an hour.
Right. So it expands on both ends of the spectrum. So that is the next direction, at least for me. The evidence, if you're following the Neuro-Orthopedic Institute, Mosley's work and Butler's work and Lowe's work, all of them are talking about, and I don't want to pigeonhole myself to say I'm moving all towards pain neuroscience and pain education. I believe that there's a complement of the two. Yeah. And this is without doing a plug. I know it sounds like a plug, but a new course that we're just starting this weekend in Colorado is the FMT vibration specialist. You talked about earlier how I'm now using vibration. The way that we're communicating this intervention, this tool, is using vibration, but I'm integrating the patient's beliefs and emotions and feelings that they're having while I'm doing the intervention. So I'm for the first time, I'm trying to integrate the individual into the treatment. Before, you'd be, I'm cupping your shoulder.
I'm doing this treatment on you.
On you, right?
Yeah.
It's a.
But I'm doing this with you.
So that with is now really pulling the individual and saying, I need you to interact with me, and I want you to tell me what you're feeling on the inside, which some would say, well, gosh, I think you're spilling over into psychotherapy. Not necessarily, because we bathe ourselves in our patients' or clients' emotions. They come in with certain emotions already.
Yeah, they wear it sometimes.
Right. All we're asking them to do is now become more curious about it. So we're asking them to now reveal what they're feeling. They're like, I feel angry when I'm doing this. So let's talk about that, and let's have you kind of talk through that as I'm doing the therapy and see if we can alter that experience. And the term is used, it's called reappraisal or reconceptualization, where I'm changing the person's emotional stance on their injury or their pain experience or their lack of movement. And I'm really excited about the opportunity to kind of present this model so we can test it in a safe and effective way, and then see if we can expand on it to be able to say, we truly can integrate psychosocial practices into manual therapy. And this is my first foray into that environment.
Where's the off-ramp for you where if you hit a certain part with a patient, you have to say you are the person where you need to go speak to somebody that's professional?
I'm glad you brought that up. So it's ultimately when the therapeutic intervention is extending outside of ultimately the practitioner's comfort zone, that I can't influence your behavior that is going to get you to the next level of your care. So when I feel like I'm up against a roadblock where the person is resistant to even the conversation, I bring up and this is where networking is critically important, to have your community around you. You talked about your local 5.
Yeah.
I want to know who are my local connections of the psychotherapy, connections, my surgical connections, all of the teams that I need around me to be able to help my patients further. When I'm up against a roadblock of someone's ability to actually express themselves, I give them the option of saying, here's some other team members that you might want to consider as part of your therapeutic
team.
Yeah, right.
So we've been going probably about an hour at this point in time, and I'm enjoying the conversation. I hope you are too. We're going to close this down. What closing thoughts do you have as far as, products, services? What closing thoughts, or what would you like the listener to take from, basically this hour that we've been going?
Yeah, I one of the closing thoughts, and it's something that I've even seen within our profession, groups within our profession, there are certain cliques that develop, and unfortunately, quite often I'm recognized as the rock tape guy. And I wish I had the opportunity to kind of alter that descriptor because I don't consider myself the rock tape guy. I might have a lot of rock tape paraphernalia, like shirts and hats and whatnot, and I love the brand, something I've been highly involved in. But I think part of it has been limiting because they feel that my colleagues might feel that that's my tool alone, and it's not. My tool is the therapeutic alliance, the relationship building capacity that we have. And my goal ultimately is to help our profession and other manual therapists help people more effectively. And I just happen to be involved with a company like this. So if I could leave anything to any of the viewers or listeners, Rock Tape, even though we sell products, our main philosophy is around how do we help people move and move in a meaningful way. And that might sound like a spiel or a line that someone would give you, but if you know any of our team, our education team, we live and breathe movement, and we feel that we're just fortunate enough to be able to share what we believe in respect to therapy.
How can people find you?
Rocktape.com if you're looking at more information on the FMT education platform, the functional movement training platform. If you're looking for more information, my social identity is Fascia Doc. I somewhat regret giving myself that specific name, but it's a name that's stuck with me for quite some time. So Fascia Doc is my handle on social, and I basically share the science of fascia on the front end of that.
There's some cool ultrasound studies posted.
I do share a lot on looking underneath the skin and seeing what's happening in real time. And then the other half of my handle is just what things make me laugh. And so I post a lot of dumb memes. So I apologize in advance if that becomes annoying. But so it's bifurcated into information about human movement and then stuff that just make you laugh, which I think is therapeutic.
Have you ever had a conversation with somebody where it was all just memes?
I wish I did, because I'm actually getting pretty good at it. And just, I have a certain sense of humor. And so I'm interacting with people with similar types of sense of humors with my choices of memes.
Gotcha. And then the upcoming courses, what's the roster for? It's September of 2022. We're almost to October. What's coming up for the next couple months?
Yeah, so the fall is always a big time when it comes to continuing education. We have, courses spanning from tape to cupping and everything in between. But the newest course that we're launching this coming weekend, as I said, is our newest course, the FMT Vibration Specialist, where we're integrating the use of compressional and decompressional vibration using tools that help emit different frequencies of vibration. But within this system that I was just communicating, how we can apply a psychosocial lens to our manual therapies using vibration. So that starts this weekend coming in Colorado.
Beautiful, scenic Denver, Colorado. All right, we've got a ton of information from him. So I'm Dr. Dino Pappas. This is the We Fix Pain podcast. This is Dr. Steve Capobianco. This episode is helping pros and Joes feel better and move better. We are signing off. Thanks, Doc.